Good evening, everyone. On behalf of TaskMed, I would like to welcome you all to Medcast Insights into Healthcare, a learning initiative by TaskMed. Today, it's a great pleasure to have with us Dr. Adeel Majid, who is a consultant interventional cardiologist at Fortis Balaji Hospital, Jodhpur, Rajasthan. We welcome you, sir. Sir,
Thank
we
you.
look forward to hear from you on today's topic of discussion, Mexelitine, an unexplored antiarrhythmic drug. Over to you, Dr. Majid.
Yeah, thank you. Thank you, Tasmit, for giving me this opportunity and sharing my thoughts on this, the unexplored antiarrhythmic agent Mexelitine. So this is not commonly used, and many of the people, they don't know where to use this particular drug, and many of the people don't know whether it is available or not in India. The topic is for today's discussion is ventricular tachycardia. The tachycardia management, especially the management of VT, is very vast, and there are a lot of drugs available, and there are a lot of actions that we need to remember whenever we are starting a particular agent, and especially the mechanisms underlying the tachycardia needs to be understood so that we can actually omit the substrate, so we can have a better management of VT in a particular patient. So VT is broadly, actually it is defined as it's a wide complex tachycardia, which means the QRS duration is more than 120 milliseconds when you do on a EKG, and it's a tachyarrhythmia which has got a heart rate greater than 100 beats per minute. And the most common cause for VT is underlying ischemic heart disease. We have seen the VT in patients who present with acute coronary syndrome, the post-MI patients. They have a primary VT, then a secondary VT. So these things needs to be remembered. And whenever we have an acute event, then we can have a VT which can be polymorphic. However, in a stable patient, patient with structural heart disease means patient who has been previously subjected to myocardial infarction or any other insult which has actually damaged the myocardium, they often have a monomorphic VT. So we need to remember this, that in acute coronary situation, the VT is many of times it is polymorphic VT, and in patients who are stable, they have a scar in the myocardium. The insult was in the past, so they often have a monomorphic VT, and this thing needs to be remembered very carefully. The other causes that include the adult and the congenital structural heart disease. Then there is some acquired inherited generalopathies, infiltrative cardiomyopathy, electrolyte disturbance, especially the hypokalemia, hypocalcemia, and hypomagnesemia, which often leads to polymorphic VT. And there are some certain illicit drugs like cocaine and methamphetamine and digitalis toxicity, which can lead to VT. So the therapeutic strategies in the management of VT, we have we have the drug therapy, then we have the ICDs, which were actually introduced in 1980s. Then we have the catheter ablation, then the sympathetic denervation. So anti-arrhythmic drugs are actually the first line of the therapy whenever we document a ventricular tachycardia or in a particular patient. So the first line of management is anti-arrhythmic drugs. They are inexpensive, they have a rapid effect, and they decrease the frequency of the ICD shocks if the patient has been subjected to implantable cardioverter defibrillator in the past. And the contraindication, the side effect is there with each antiarrhythmic drugs that needs to be remembered, and the therapy is often a lifelong therapy. Then the ICD are basically used in secondary prevention of the VT or the VF, and they can be used also in primary prevention with some ischemic and non-ischemic cardiomyopathies. And the inherited cardiomyopathy, we know that this patient is going to have a VT in the future, so they can be given a implantable ICD defibrillator. They have a mortality benefit, but they does not prevent the VT. This thing needs to be remembered. ICD are there to treat the VT, but they does not prevent the VT. So uh, they increase the mortality risk with shocks. They have an infection and they have a procedural complications. Then the catheter ablation, they like especially if the patient has have VT storm or recurrent or idiopathic VT, then the catheter ablation can be there. The catheter ablation can be done in patient with ischemic VT and scarred VT. It is commonly used, and the catheter ablation can be given to these patients. Then some inherited disease, especially like Brugada syndrome, and when the patient has a VT, and then the ARVD is also in the way the catheter ablation can be used. They reduces the VT burden, they reduces the frequency of the ICD shocks, but they decrease the need for the AADs. But these procedures are invasive, they are often time taking, and there can be associated procedure complications, and they are often repeatedly done, especially in patients who had ARVD and Brugada syndrome. Then the sympathetic innervation basically is for the refractory VT. They reduces the VT burden and frequency of the ICD shock, but they are actually having a very limited evidence. So the anti-arrhythmic drugs, this von William classification. The von William classification, it's actually a old school classification, and this is used very commonly whenever we think of anti-arrhythmic drugs. We have been taught this classification while during MBBS, even in the postgraduate. But when you come into the field of interventional cardiology, the classification is replaced many a times with the modified classification, and we have the other classification, especially the Sicilian Gambit classification, which actually tells us the substrate, and that actually gives us the target oriented approach with the particular agent. So the in von William classification, we have the different drugs like class 1, which are the sodium channel blockers, then the class 2, which are the beta blockers, class 3 is potassium channel blockers, then fourth are the calcium channel blocker, then there are certain other agents. So the class 1A agents is classified into class 1A, B, and C. And the class 1A, which quinidine, procanamide, disopyramide. Then the class 1B, the lidocaine and the mexelitine. Then the class 1C is flecainide, propafenone, and moxazine. Then the class 2 are the beta blockers. Then class 3 are the amiodarone, sotalol, dofetilide, ibutylide. Wait करो. Then the class 4 are the diltiazem and the verapamil, especially these calcium channel blockers. Then there are certain other agents like adenosine, digoxin, and magnesium sulfate. Basically, magnesium is often given in patient with polymorphic VT. Then the adenosine is often given with supraventricular arrhythmias. So the pharmacology characteristics of the antiarrhythmic drugs used for ventricular arrhythmias. So we have the amiodarone. I won't be going into the detail. Amiodarone is commonly used whenever a patient is documented with broad complex tachycardia. You can give a direct bolus of amiodarone, provided it is VT and it is not a pre-excited VT. Pre-excited VT means the VT which is associated with pre-excitation syndrome. In that case, the amiodarone is usually not given. So the VT should not be pre-excited, and the broad complex tachycardia, whenever we encounter, the amiodarone can be safely given as a bolus, and it often terminates the VT. And actually, and it has got very electrophysiological effects. Means it can lower the sinus rate, the QRS is prolonged, the QTC is prolonged, the heavy nodal refractoriness is increased, and it increases the DFT also, that is a defibrillation threshold. But it has got a lot of adverse effects, and especially the hypotension, bradycardia, AV blocks, then TDP. It slows the VT below the programmed ICD detection rate and increases the DFT. And other extra cardiac effects, a lot of them, that is like corneal microdeposit. It can cause thyroid abnormalities. The patient can develop hypo or hyperthyroidism. Then it can cause the CNS effects like ataxia, and then nausea, emesis, constipation, photosensitivity, discoloration, especially the discoloration. The patient becomes dark whenever he is on this amiodarone oral therapy. Then like peripheral neuropathy, it can affect the liver also, and it has got pulmonary fibrosis and pneumonitis. So these variety of side effects needs to be remembered whenever we are starting this particular drug. But the dose that we give, if the total dose what we use is, if it is less than 300 milligrams in a day, then these side effect can be decreased significantly. Then the second agent, that is the lidocaine, which is commonly used as a VT, commonly available with the name of Xyrocard, can be given directly IV. and bolus can be given then followed by a repeat bolus and can be given as a maintenance dose, and it can lead to bradycardia and hemodynamic collapse, AV blocks, sinus arrest, and it has got other effects like delirium and psychosis, seizures commonly. But the beauty of the class 1B agent is that, especially the lignocaine and the mexilitine, is that they have got very limited effects on the cardiac intervals, the sinus node, the AV node. They have very limited effects on these uh, structures. So the sinus node is often not affected. Even the AV node is often not affected, and they have where even the other intervals are not affected. The QTC, however, it can be slightly shortened, but there is not a remarkable effect on the overall QTC. Then the metoprolol, which is given IV in a dose of 5 milligram over 5 minutes, can be repeated over 3 times, used in VT, and it is a beta 1 selective receptor antagonist. And often rates if the sinus node is low, it has got effects on the AV node, and the refractoriness is increased and can lead to bradycardia and hypotension. So, and the mexilitine, which is used in VT, VF, VVC, has a role in patients with LQT3 also. But it because the LQT3 often involves the SCN5A channel. So this actually mexilitine has got effect on the SCN5A. So it has got effect in patients who has been given a diagnosis of LQ23. And as I said, that it has the class 1B agent that doesn't have marked effect on the most intervals, and the QTC can be slightly shortened. That's why they have been used in patients with LQ23. And the cardiac effects are also not very much. And but these drugs should not be used if the patient has underlying sinus nodal disease, because if the sinus node is normal, then this drug can be used. And this drug is basically a oral substitute of lidocaine. So oral, and this is not commonly used alone. This is usually as an add-on agent when together with amiodarone, sotalol, or other antiarrhythmic agents, especially the class 1A, the propanamide, quinidine. This is an add-in agent. This drug should not be used as a alone therapy. So the mexilitine, then the propanamide class 1 agent, which is given as a loading dose followed by maintenance. They have effect on the QRS is prolonged, the QTC is prolonged, it increases the DFT, and it can often lead to TDP if it is not given properly. Then the sotalol, it is often used in the hospital. It has got a potassium channel blockade with beta 1 and beta 2 receptor antagonist activity, and it often slows the sinus rate. QTC is prolonged, AV nodal refractoriness is increased and decreases the DFT. However, the other drugs, they increase the DFT, and it has got bradycardia, hypertension, syncope, and can lead to TDP also. So the mexilitine is actually improved in ventricular arrhythmias by US FDA for the treatment of VT, and so it is an unexplored drug. And the mexilitine is amongst the recommended antiarrhythmic agent to prevent or to treat VT and VF. And in 2014, the European Society, the Heart Rhythm Society, and the Asia Pacific, it recommends that the mexilitine amongst the recommended AED in patients suffering from symptomatic non-sustained ventricular arrhythmias on an adequately dosed beta blocker or a non-dihydropating calcium channel antagonist, so as to improve symptom associated with arrhythmia episodes. So it is to be used always in combination with the other antiarrhythmic agents. It should not be used as a alone agent. And it is an oral container of lidocaine, and the dose should be properly uptitrated. And mexilitine is among the recommended AED for patients with structural heart disease and recurrent monomorphic VT in addition to ICD and ablation. Means the patient who has previously has gotten a scarred myocardium because of the post-MI insult. Now he is having a monomorphic VT. So after catheter ablation, especially we commonly add this mexilitine as an add-on agent to prevent the recurrent episodes. So it's a class 1B agent, sodium channel blocker. Structure is similar to lidocaine, but orally active, inhibits the inward sodium current and reducing the phase zero. And the site of action is basically the Purkinje fiber. As I've said previously also, that it doesn't have effects on the sinus node as well as on the AV node. And though the ERP is decreased, it results in increase in the ratio of the ERP and the action potential duration. So its electrophysiologic properties are similar to lidocaine. The patient with normal conduction system, they have a minimal effect on cardiac impulse generation and propagation, and no development of second degree or third degree AV block, and no prolongation of the ventricular depolarization. That is, the QRS duration remains the same. However, if with the class 1 agent, the QRS can be prolonged, but if with the class 1B agent, the QRS duration remains the same, and the QT is slightly decreased. And patient with pre-existing, like if they have a sinus nodal, it can cause sinus arrest, sinus depression of the sinus rate, then prolongation of the SNRT, which the sinus nodal recovery time, and decrease the conduction velocity and increase the ERP of the interventricular conduction system. So these are the effects of the Mexelitine. You can very well see every antiarrhythmic agent like amiodarone, disopyramide, the class 3, the class 1A agent, the class 1C agent, all have the effects on the cardiac interval, especially they have the effect on the sinus node, they have the effect on the AV node, the PR interval, the QRS duration, the QT interval. But the lignocaine and the Mexelitine, if you see, they have got very minimal effect on these structures. So Mexelitine, it has got none, it has had got no effect on the SC node, AV node. It acts on the Purkinje fibers, no effect on the intervals as well as the durations. So doesn't have any effects on hemodynamics. Means the small, it usually is not statistically significant decrease in cardiac output, no significant negative inotropic effect, and blood pressure and the pulse rate remain essentially unchanged. And however, there is a mild depression of the myocardial function, similar to that produced by lidocaine, and occasionally with IV therapy in patients with cardiac disease. So it is well absorbed 90% from the GI tract, and the peak blood levels reached into 3 hours. It is often given with the food because it has got a effect on the GI effect can cause GI irritation. The volume of distribution is large, and the metabolism, first pass metabolism is low, and it is excreted unchanged by the kidneys. And the plasma half-life is almost 10 to 12 hours. So that's why the BD dosing is recommended. Many times the TDS dosing, depending upon the use. So the doses must be individualized on the basis of response and tolerance, and both of which are dose related. And administration with food or antacid is recommended. And initiation dose is 200 milligram TDS when rapid control of arrhythmia is not essential. And minimum of 2 to 3 days between the dose adjustment is recommended. Means we cannot step up the dose immediately. We have to wait for at least 3 days. And the dose may be adjusted in 50 to 100 milligram increments, up or down can be done. So when a rapid control of tachyarrhythmia is essential, the loading dose 400 milligram can be given, then 200 milligram TDS and continue as per the chronic treatment. And the rapid control is not essential, then 200 milligram TDS followed by 300 milligram TDS, then 400 milligram TDS can be given depending upon the response. And the dose can be increased over a 3 days interval. So the contraindicated like cardiogenic shock, the pre-existing second degree AV block, the existing sinus nodal disease, third degree AV block, if no pacemaker, these drugs should not be given when we have the documented underlying sinus nodal disease or a cardiogenic shock or other conduction system disease. It is generally well tolerated, but there are some reversible GI and nervous system adverse reaction like upper GI distress, lightheadedness, tremor, and coordination difficulties. So this is the management of sustained VT. You can very well read it. It is often given in the textbooks. I won't be going into the detail, but in summary, it is the Mexelitine is an antiarrhythmic agent which is indicated in sustained ventricular arrhythmia. It is an agent with moderate potency. Remember one thing, that it is always used as an add-on agent over the other therapies, especially the class 1A, class 1C, as well as the amiodarone, sotalol. It is used as an add-on agent. It is never used as an isolated therapy. It is safe in LV dysfunction, safe in QT prolongation, can be used in patients with long QT3 syndrome, and it has reversible non-lethal adverse effect, and it is a class 2 recommendation by the guidelines for the management of VT, and can be used as an add-on drug to amiodarone, sotalol, beta blockers, or in patient with ICD. So the management VT involves 3 major modalities: medical treatment, device and ablation, and very often the hybrid therapy is required. And treatment of VT can be a challenge and it needs to be individualized. And structural heart disease and high-risk polymorphic VT ICD is the first-line therapy, and catheter ablation is considered early for recurrent symptomatic idiopathic VTs, and as a second-line therapy for VT in structural heart disease. And medical therapy is acceptable for minimally symptomatic idiopathic VT and low subgroup of polymorphic VT. Thank you.
Very well operated, sir. So I'll request the participants, if they are having any query, they can put their questions in the Q&A box. So there's one question, how long it should be continued? You could answer.
Actually, in the first slide, the VT therapies, they are often considered lifelong, unless the patient is having especially the distressing symptom like the gastrointestinal or the nervous system. This drug can be continued as an add-on therapy. However, if the symptoms are actually there, then this drug can be discontinued and the main primary therapy should be considered. This is always used as an add-on agent. This should not be used as an alone treatment for the management of VT.
So if you allow, we can conclude the session, sir.
Yeah, sure.
Thank you, Dr. Majid, for joining with us today. It was really an insightful discussion for us as well as for our listeners. I would also like to thank all the doctors for being with us and for their active participation during the session. Thank you and have a great day.